Or, hi everybody again. I'd say how's it going, but I can't actually hear or really communicate with you. In case you missed it from last time, my name's Storm. My pronouns are they, them, their. I am the volunteer coordinator for the Rape Victim Advocacy Program. I'm also a full spectrum doula with emphasis in abortion doula services. Here at RVAP, I do a lot of work with survivors of medical violence, which we talked a little bit about in the last presentation that we had. I'm also just coming back from vacation, so I hope that my brain isn't entirely as scattered as it was for the past week. So if it is, you'll just have to forgive me. But yeah, I'll let Shalisa introduce herself.
Hello, my name's Shalisa, and I also work at RVAP as the campus prevention educator. Excuse me. And mostly what I do is I do violence prevention education across campus for staff and some faculty, and then also primarily undergrads. I'm also a doula, and I think that's all. I was not on vacation, so I have no excuse.
I'm glad to have you with me today too. It's been a pleasure working on this project with you.
Those are cool pictures of us.
Yeah, these are cool pictures of us. Just in case we don't look as cool on the webcam too. Actually, that's one of my favorite pictures of me. Anyway, let's do a little bit of a recap for what we're gonna, or rather, I guess we're talking about. Yeah, last time. Okay. So last time when I gave a webinar, which was like about a month ago or so, we defined obstetric violence and medical violence. We also explored a history of birth care and gynecology in the United States, especially with emphasis on the racist origins of a lot of the way that gynecology is constructed in the US. If you'd like more of a review of that, or if you didn't attend the last webinar, I hear it's recorded somewhere out on the internet. I think it's somewhere on Iowa CASA's advocate website too. We also talked about the professionalization and medicalization of birth care and how they impact birth outcomes. And then we very, very briefly did an overview of the Black maternal health crisis in the United States.
Awesome. Thanks, Storm. So today it'll be connecting the dots part 2, and so we'll talk about the impacts of advocacy. And so we're going to briefly explore consent in healthcare. We're going to talk about the impacts and the impacts of advocacy and the importance of advocacy in healthcare and birth settings. And then we're also going to talk about like how doula services and other health advocacy programs can help to combat medicalized sexual violence. And then we'll also talk about the impacts of postpartum care and aftercare. And then we're going to end by doing an activity where we'll kind of make a list, and the list will consist of things that we can do once we leave this training.
Yeah, and I think this webinar is a little bit more interactive too, so I hope y'all are up for it.
All right, so the first thing we need you all to do is to get a pen and or piece of paper. No, if you get a pen, you need a piece of paper. Or you can just type this on your laptop or computer or put notes into your phone. But we're going to briefly talk about identities. And so if you could draw the little stick figure that you see here, and then fill out some of the identities that we have here. We also want to just recognize that we realize that this is not all of our identities, right? These are just a few of them. And then, yeah, we'll chat in a minute. So we'll give you a couple, maybe 30 seconds to write some of these down. All right, so if you all would be willing to use either the chat function or the raise your hand function, which of these identities, which of these do you think about the most? This is one of the times where you need to interact with us, or we would like you to.
I see.
Okay, race, gender, okay. So which of these do you think about the least? I see gender is the most, education, ability, right? So oftentimes the identities that we think about the most are the ones that we feel like impact our day-to-day living, correct? And then oftentimes the ones that we think about the least are the ones that we feel like least or that impact our day-to-day living the least, right? So how do these identities impact how we do advocacy? And you can use the chat function or raise your hand also. So like, how do your identities impact how you do advocacy? Storm, do you want to give us an example?
Yeah, okay, I'll give y'all an example. I think they're probably taking a second or two to type some stuff out because this is such a complex question to answer. So if I had to like pick between two different identities, one being in my most category and one being in my least category. So like I'll pick most for gender identity and then least race. So I think about my gender identity impacting me a lot in the advocacy that I do, in that there are times where my gender presentation is advantageous to me, and then there are times where it is not. But I think, like, especially when I'm doing my work, I'm a non-binary person. Almost none of my clients actually call me by the right pronouns. Sometimes they'll also call me by the incorrect name too. And I just like, I set that aside and I accept that that's something that's going to happen. But then like, I will not tolerate being misgendered from my colleagues, because that for me is supposed to be a space where I need to be able to go to feel supported. And then there are other times too where like I will see that clients will prefer to have a female advocate, and I am not female, but then I will also get pressure from some of my colleagues to say, well, you know what that client really means is they want someone who's not male. And I say, no, that's not what they asked for. They asked for a female advocate, which I am not. So stop pressuring me to take this case. Other times, like when I think about an identity that impacts me the least, race, I'm white. So there are times where clients are more willing to accept me as their advocate or take me on, or feel like they will identify with me more solely based on the fact that I'm white. And I have seen other times where clients have rejected colleagues of mine too on the basis of race. And they've chosen me over them on some of those occasions. And while they have the right to do that, that's really racist and really dicey. And then like even like advocating with systems partners, like I know that with white privilege, it enables me to be taken more seriously by certain entities and people in power just because of that privilege that I hold too.
For sure, thank you. I think it's important to think about how our identities impact us both positively and negatively in terms of how we do advocacy. Thanks, Storm, for answering that. I actually didn't get any responses in the chat. So we'll go ahead and move on, but that's just something that we'd like you all to think about as we go through this presentation today, is just how do your identities impact how you do advocacy, and even more so like how you get to show up to your advocacy and in the world. So. All right. All right, so now we're going to talk about consent and advocacy. And again, we'll want you all to interact with us. 1 second, I'll check the chat. So someone says language, excuse me. I speak English, so everything in our culture is catered to me. Yeah, that's very true, right? Like when, if for those of us who live in the US, if English is your native language or your first language, then like most services are catered to you, right? And if that is not the case, then most services aren't. Do you want to add anything about that, Storm, before we move on?
I don't think I have anything to add, but thank you.
Thank you. All right, so now we're going to talk about consent and advocacy. Typically I would define what consent advocacy is, but since we're talking to advocates, I know that you all know what consent and advocacy is. So instead, for advocacy, can you all tell me some of the benefits of having an advocate? Like, what are some of the benefits for someone having an advocate? And I know y'all have lots of answers because we're all, or most of us, at least on this call, are advocates.
Knowing their
Helping someone know their rights. Yeah.
Fighting for their rights.
Yeah.
Voice.
Helping someone, being the voice for someone. Helping them, getting folks to kind of like listen to them, right? Mm-hmm. Being the middle person so they don't have to reach out all the time. Yeah, for sure. Providing support, free services, right? Especially if finances would be a barrier to someone accessing services. Another one says helping people understand information they can't understand otherwise. So like the criminal justice system, having a constant person by their side through their journey. When I think of advocacy, I go right to that. Having someone that's going to be there with you throughout your journey, whatever that journey is going to be. Helping them find the right words for what they're going through, not being alone, knowing their choice, knowing the choices that someone will have. Yeah, so lots of benefits to having an advocate, right? We all know this because this is the work we do. So what are the benefits of practicing everyday consent?
It becomes a habit. It builds trust.
Yeah, so it'll become a habit. So the more you practice something, the better you get at it, right? So like riding a bike, or if anyone plays any sports, like the more you play the sport, I'm sure you weren't as good at it when you were 5 as you are now. Empowerment, yeah, for sure. Ensuring that one is not crossing people's boundaries, right? Thinking of boundaries as like a form of consent, right? Restoring autonomy, yeah. It sets an example for those who don't do our work, yeah. Especially thinking of like going into medical spaces, right? Sorry, I just want to make sure I didn't miss any. All right, yeah, those are great answers. Someone says it sets an example for those who don't do our work. Okay, sorry, I already read that one. But yeah, so like the benefits of practicing everyday consent like really positively impact everyone around us, right? When I think of everyday consent, we often talk about consent in like sexual spaces, right? And one of the ways that I think of practicing everyday consent is with my colleagues. Storm is one of those, and from the chat, I can see some of my other colleagues are on here. So one of the things that I like to practice is now that it's, now with COVID, it totally changes it, but even before COVID, before going into someone's personal space, like their office, like stopping at the threshold and asking them if it's okay for me to come into their office. And then also if I'm going to talk to someone about something fairly difficult, making sure they're in the space to have that conversation. So those are some examples of everyday consent. I think one of the things that I've seen quite a bit with COVID is like this negotiation, right? Like, and so COVID-19 in the terms of like how we're interacting with folks is also another way that we're practicing everyday consent, right? Before you're hanging out with someone, figuring out like what their boundaries are, right? Before maybe in your office, whenever someone walks in the door, they need to have on a mask, or I know at our building, down by the front door, we have a space where you can get a mask. There's some tissue down there, and there's somewhere for you to sanitize your hands. And so like making that a part of like our practices. And I also see that Jocelyn just put the link to the first part of the webinar series. So this is part 2. So yeah, but anyways, I feel like COVID-19 in some ways is reinforcing the need to practice everyday consent. All right, and so I'll turn it over to Storm.
And then branching into practicing of everyday consent. So it might work better if you actually raise your hand for some of these next discussion questions. But I want you to like start thinking about those conversations of practicing everyday consent and then bridge them into thinking about what are some ways that you all have advocated for clients in medical spaces. So like we'll start there. Does anyone have like a story they'd like to share about this? Okay, we got somebody that raised their hand. How do I click on
I can get it.
Okay.
Can you hear me?
Yes.
Okay. I think back to one of my, probably my first 2 months while as an advocate, and I responded to an essay at the hospital, and it was with a minor child, and they were not English speaking. And the doctors and the nurses that were there were so pushy to go ahead and do the kit, even though, you know, this child, she was 12, you know, but she's still a child, and the child is screaming no and screaming that she doesn't want anybody to touch her. And, you know, it took a lot of advocacy and phone calls to get these people to just step away from this child. And I don't know that, you know, what the barriers were, besides for the fact that they didn't want to contact the CPC. They felt like it was going to be, you know, too long before she could get seen by them, and they wanted to have this evidence, which is all understandable. However, you're basically doing the same thing to this child again, and you're touching her in ways that she does not want. And that was kind of my argument on it. And so that one will always stick out in my mind.
Yeah, and it sounds like you were really advocating against medical violence happening to your client. I think that people like believe that children are owned by adults, and therefore because they are owned by adults, they don't have the right to say no to certain medical procedures or even just like medical examinations too. But like if we think about just how much the trauma of having something done to you without your consent weighs so much more than whatever the possible benefits, if there will be any benefits to having that exam done, could be too, especially considering a decent number of sexual assault forensic kits don't manage to collect DNA or other forms of forensic evidence in the first place. Not because, of course, people are not lying, it's just bodies aren't made to hold evidence in that way too. Thank you for sharing that story.
Yeah, that's the part that just disgusted me. It was like, okay, you're sitting here saying it's not acceptable for this man to have touched you, but it's acceptable for this male doctor to touch you, you know, and it's like, you don't have a choice either way.
Yeah. And that's, your examples are a really good example of a lot of the ways in which we do medical advocacy for clients, because I think there are a number of advocates that have a similar story where ER healthcare practitioners, or sometimes even the SANEs, are getting really pushing a sexual assault forensic kit onto a person when they absolutely don't want it. There was like a point in time where I had talked to a SANE when I was working in Des Moines, and she had told me that the #1 complaint that they had against SANEs in her region was consent violation, which was absolutely jarring to me, because the point of having a SANE in the first place is to respect somebody's boundaries, but because it's systemically built into the medical system to push people's boundaries, of course, it's going to carry over into this space too.
Especially, I think, when you have law enforcement that's hovering over, you know, pushing this as well, and not taking the time to see anything more besides the fact that they want that kit and they want to leave.
Yeah. Thank you for sharing. We've also got some input in here from Emily. She said consent for medical exam options, informed consent before medications or parts of the exam, informed consent for surgery, rights of children, right to interpretation. Yes, a lot of these are some of the key components of medical advocacy. I've also got a comment in the chat from Sarah, who said, I helped a kid escape from the hospital. She didn't want to be there or have an exam. I told her how she could safely get out of the building. She was probably 14. Wow, that's really heavy. Yeah, that's hard stuff. And y'all have got really good examples here of the ways in which you've advocated for clients in medical spaces, especially considering so much of traditional advocacy as we see it occurs in the medical space. Let's talk about another thing. What are some ways you've witnessed medical providers use consent with clients, maybe even in a positive way? I see somebody raise their hand.
Hi.
Hi.
Are you able to hear me?
Yes.
Wonderful. So there is one person I can think of, a sexual assault nurse examiner in one of our counties, that whenever I respond to the hospital, regardless if she's doing a sexual assault exam or a domestic violence exam, she goes beyond the paperwork. Other than just having people sign that they consented, she'll say, like, even if she walks around somebody, is it okay if I touch your shoulder? She'll show them the tools, and she'll explain what they do. And she's like, you know, how are you doing? Are you okay? Do you need me to slow down? Do you want to go through with this part of the exam? Do you want to have family members in here with you? Do you want to have the officer in here with you? So I think that person I'm thinking of definitely goes above and beyond. And that's something I always think about when I think about medical providers using consent with clients, and they always tend to really appreciate that. And that's something I also echo. And I think it's really nice too, because the nurse examiner will always look over at me as well and say, like, you know, is there something else that I missed that you think may be important? And if I think maybe there's a part of the story that the client may want the nurse to be aware of for looking for, like, maybe certain bruises, I'll like talk to the client and say, hey, you know, do you want me to share this part with the nurse? And if they're okay with that, I'll say, like, you know, I think her neck was grabbed. Do you want to look at the neck again or something? So I think it's a really good partnership with advocates as well.
Yeah, and you know, like from your story too, it sounds like that SANE really uses a lot of trauma-informed care approaches with the way that she's practicing medicine too, which is really nice. Thank you for sharing that. Let's see if we've got some things into the chat too. I think there's one sentence that kind of cuts off, so I won't really go in. Oh wait, here we go. They've got like a SANE that has a background in working with people that has mental illness, and they said, I always learn so much from her. She asks for consent from everything. We should do that with every client. Yeah, absolutely. And it, like, sometimes I think too, like a great way to think about consent is also taking into consideration things that you wouldn't necessarily have thought of before. I think like that's part of the basics of medical providers using consent, is being considerate. Because oftentimes, like, it's just so built into the routine, like, oh, why would I need consent to use this tool or that tool? Why would I go through the entire surgical procedure from top to bottom with you rather than just tell you what we're doing in here? Well, because it's entirely necessary, and there may also be parts of that procedure that person doesn't necessarily want done. Let's bridge into what are some ways that y'all can think of to improve consent practices in medical spaces? Come on, attendees, be so smart. Come on, attendees, raise your hand. No? Okay. Well,
I think one of the ways is, can I answer it?
Yeah, answer it.
One of the ways to improve consent practices in medical spaces is not asking questions that where the answer, like where there's like an implied answer. And so my favorite example is thinking of like when I was a child and my mom would say something like, you're gonna clean your room, aren't you? And it's like, well, I can't say no to that, though I would try sometimes. But like thinking of that also in medical spaces, so like when providers suggest something, or when providers ask a question that where no is not really the answer that they're looking for.
Yeah, I see that happen a lot, especially like with the clients that I work with too. I'm also seeing some other things in the chat here. Somebody says listening more. Another person says, I've seen providers struggle with adult patients who have legal guardians, allowing the guardian to make the call on an exam. Yeah, I see that a lot too. Like, we believe that just because someone has a legal guardian, or oftentimes like people with legal guardians have disabilities, mean that they can't make medical choices for themselves. And that's not entirely true at all. We have to prioritize what that person wants, regardless of what disabilities they may or may not have. Thank you everybody for sharing too. Also taking their time. I've seen people try to rush or push choices. Yeah, a rush decision oftentimes leads to a decision that somebody doesn't necessarily want to make, and people need time to be able to decide what they want to do. And there's also like a language barrier issue. The client, as much as possible, the client should fully understand. Yes, true. You have to be able to make the information that you're relaying understandable to that person before they can make a decision. All right, let's move on to the next topic. Shalisa, you're in charge of the PowerPoint. Oh, thank you. All right, so when we're talking about birth work, I think it's important to remember that birth work is a form of advocacy. It's a form of advocacy for a variety of reasons, but the first being that it's about human rights. Like so many of y'all have disclosed in the examples that you've given in the chat and otherwise, it's about protecting the human rights of an individual, especially their right to say no, involving protecting their bodily autonomy. So doulas and advocates have that in common a lot. Oftentimes when we're both advocating in the medical spaces, it is part of our job to protect that person's bodily autonomy, because there are so many challenges to it within the medical space. And still too, a lot of those challenges are steeped in racism, xenophobia, queerphobia, transphobia, ableism, misogyny. If there's a form of oppression, you name it, it's going to impact the way that that person receives services. And so part of our jobs as advocates, also like as birth workers too, is fighting all of those things, because it's what creates a more equitable environment for folks. Similarly too, we're also ensuring that people have all the information that they would need to make decisions about their reproductive health. So much of sexual assault advocacy and birth work relates to reproductive health, and that it's all about assault or consent, or thinking about just birth work in general. Sex is how babies come into the world in the first place. So you have to have adequate access to knowledge about reproductive health care and access to reproductive health care as a whole. So like there are oftentimes too, like when we're thinking about a full spectrum doula approach, that means making sure that people have access to reproductive health care. I do reproductive health accompaniments all the time that aren't even necessarily pregnancy related, just because people need that advocacy in that space, especially with so much pushing and power and control that happens there too. To have a better grasp on comprehensive sex education is also necessary too, because if you don't have the knowledge and the tools to be able to make those healthcare decisions, then you're not able to truly access consent in the way that other people can too. So a lot of birth work is about ensuring that people have comprehensive sex education. Or like, for instance, I think of times where I've sat with clients and they don't even know what their own cervix looks like. And so we go to the Beautiful Cervix Project, which is this website that's on the internet of people just, you know, your everyday people taking pictures of their own cervixes at different parts of their cycle or with different conditions too. and showing them this is what this part of your body looks like. This is what this exam is useful for. This is why this form of healthcare may or may not be necessary for you. And it's also about economic equality. So oftentimes doulas, especially like in the realm of birth workers, are a service that you have to pay for and they're not covered by your insurance, which is really unfair because there's a lot of benefits to having doulas present, and it's substantiated by research too, and it results in having better birth outcomes. And I think that advocacy is the same way too, in that there's so much of advocacy that goes to emergency financial assistance for clients, housing, also just helping them obtain the necessary resources that they need to survive after leaving an abusive situation, or trying to recover from an assault and deal with the aftermath of it. So there's so much crossover between advocacy and birth work. Essentially, like, birth work is a form of advocacy because birth work is social justice work. And yeah, that's what I got to say about it. I'll hand it over to Shalisa.
That's all you have to say?
Yeah, I guess.
All right. And so birth work is also anti-violence work. Birth work it's believing in survivors, which we all do. It's one of the reasons that we're probably a part of some of the work that we do. It's also restoring control to survivors. So some of the examples you all gave earlier were around like helping, like when advocating for them, making sure you're giving, you're like amplifying their voice and what their wants and or desires are. It's prevention. So similar to like some of the work that I do, and then also some of what this workshop is, right? Like one of the things that we want to do is prevent harm from happening before it even happens, right? And so also thinking of it as, ending obstetric violence, which I know a lot of the work that Storm and I do is around this, and we advocate on behalf of this all the time, but then also just knowing that, like, as even without being like a doula, right, just being an advocate, like you can also impact that. Addressing and ending systemic medical discrimination. And so thinking of some of the examples that Storm gave a bit ago. So like one of the things we're wanting to do is not just address it, but we want to end these things from happening. So, alrighty. And all right, so what is a doula? So a doula is, we're going to talk about all the different, well, not, these aren't all the different types, but these are the ones that Storm and I are highlighting today. So doula is a trained professional who provides continuous physical, emotional, and informational support to a birthing person before, during, and then shortly after the childbirth. And this is to help them achieve the healthiest, most satisfying experience possible. A full spectrum doula, which you'll see furthest left on the screen, may also support folks who are seeking abortion, provide childbirth education, and also provide pregnancy-related counseling. And so we also want to talk, there's a difference between birth and postpartum. So a birth doula is someone who helps the birthing parent while they're giving birth. So usually before, during, and then just briefly right after. A postpartum doula is during the postpartum period. So after a birthing person has birthed, has typically birthed after their pregnancy. That's what I want to say. And so for also in terms of the birth doula, there's also a fertility doula and a sex doula. And you all should totally look those up. I can give more information after this also. And then postpartum doula also does some work around abortion and or infant loss and miscarriage. And I know that Storm and I both do quite a bit of work around abortion and then also some infant loss and miscarriage. And then I will be going through a training here in October. So I've been saying like in a few months, now it's just in 1 month, to become a sex doula and to do some work around that. So we also just want to mention that every doula should be trauma informed. And I see that got cut off somehow from our presentation, but that's okay. Every doula should be trauma informed, and being trauma informed and sensitive will greatly impact the kind of advocacy that that individual provides for a birthing person. All right, so now we're going to talk about advocates and doulas. And so if you all would be willing to either raise your hand or type in the chat box, what are some of the benefits of having an advocate? We actually we talked about this. Sorry about that. We'll go to the second one actually. What are some of the ways you all have advocated for clients in medical spaces?
Wait, we already covered this one, I think.
I thought that was about consent, but okay.
That was about consent. Never mind. Excuse me. That was about consent.
We'll just go on to having a doula. So what are some of the benefits for having a doula? If any of you all have ever had a doula, or if you've ever worked with a doula when providing services for a survivor. All right, let's see, there's some. So to be informed about things that we don't teach in schools. Okay.
Like having a pregnancy/birthing advocate. Yeah.
Mm-hmm. So I've never had one for a client, but a doula is also great support for birthing. For pace and control, yeah, for sure. They help keep you on your plan if you get tired and forget. I have a friend who is a doula, and they nurture, support, and offer guidance to pregnant people in different ways than I could. Yeah.
Yeah.
What do you all think would be the benefits of having an advocate and a doula, right? And it doesn't have to be the same person, but like if you as an advocate would also provide support and that individual would have a doula, what could be the benefits of having both at the same time? Breaking isolation. Attending to the holistic needs during the birth. Yeah. So doulas can do house calls. Yeah, you're right. Actually, so much of the work that postpartum doula does is house calls, right? And even before, even if you're a birth doula, even before the child is born or before the birth, like you're doing mostly house calls. Well-rounded support, right? It kind of makes me think of like the two heads are better than one kind of thing. And so thinking about like if you have two individuals there to support you and amplify your voice, like how empowering that would be. So, all right, thank you all.
Something that I want to talk about in this section is that health is interconnected, especially when it comes to birth care. So like some things that we know about doulas in general is that there's a lot of research showing like just how beneficial they can be. There's been at least 26 trials of over 15,000 people, and overall people who receive continuous labor support. So that can look a variety of different ways. It might involve the person's partner. It might involve having somebody who's trained to provide that continuous labor support, but it's not typically necessarily a healthcare provider providing that continuous labor support, although it is quite beneficial to have that. So you'll see like a lot of hospitals will have nurses staffed with the birthing person through the entire process. But people with continuous labor support are more likely to have A normal vaginal birth, they're less likely to receive pain medication. They are less likely to have negative feelings about childbirth, less likely to have a C-section. Their labors are shorter. Their babies also tend to have less complications in birth. We also see about a 25% decrease in the risk of a cesarean as a whole, which is, it's pretty huge considering about a third of people birthing in the United States have C-sections too. We also know that there's an increase in the likelihood of spontaneous vaginal birth too. So it's like about an 8% increase in it when that person has a doula present. Additionally too, there's like a 10% decrease in medications for pain relief, especially if the type of person providing continuous support did make a difference too. So then, and other things that I can think of as well as that there's a 38% decrease in the baby's risk of a low 5-minute APGAR score. There's no data on if the type of person providing continuous labor support particularly makes a difference. But another like concrete thing that I hear mentioned a lot in like talking about birth work, especially in doula trainings that I've taken, is there's often something called the phenomena of emotional dystocia. So sometimes labor gets stalled and people can't really pinpoint a reason for why that happens. And oftentimes it's because that person who's in the process of giving birth has emotional needs that aren't necessarily being met in the space. They might be afraid. They might feel uncomfortable. I mean, you know, more uncomfortable than you generally would giving birth, because birth is pretty uncomfortable for most people when they're going through the process of giving birth too. But a part of what doulas do is they help promote that holistic approach. So that allows the other practitioners to just focus on the medical aspects of their job, while a doula is promoting that approach of caring for the person from an emotional standpoint, albeit like you still need to have good bedside manner as a medical practitioner, but doulas can also help prompt people into those things that support good bedside manner, like prompting people into consent practices, or maybe asking if that person needs a snack or needs more ice chips if they're in a hospital that's discouraging eating throughout labor too. They're helping make sure that the environment as a whole is supportive of that birthing person too, that they have people in the room that are supportive of them, not everyone that's in that person's family that insisted grandma just absolutely had to be there at the time when that person maybe doesn't want that person there. And also they're helping that person maintain like a sense of spiritual well-being too. So like, I think we really forget birth isn't just a medical phenomena. It's not inherently a medical phenomena. It's bringing a new human being into the world. And that's a really spiritual experience for a lot of people. And it has to be recognized as that if we're looking at health from an interconnected, holistic approach. I'll hand it over to Shalisa.
Thanks, Dawn. All right, so what's the role of a doula in combating medical violence? It's amplifying the voice of the birthing person, providing evidence-based information, providing options, so letting them know what their options are, and then also providing emotional support, which we've heard multiple times during this webinar, and then also just being there, like bearing witness. So yeah. So now I'm going to turn it back over to Storm.
Okay. So let's talk a little bit about some of the practical suggestions for advocates too. So these are some of the things that I've used a lot in, so I guess I'll back up a bit. A while ago, about a year ago or so, our VAP constructed this program that we call the Queer Health Advocates Program. We constructed it because we had conducted surveys and a number of queer people felt unsafe in medical spaces and felt like having non-emergency medical advocacy was something that was really important to them to get better access to healthcare, and also promote a positive relationship with their healthcare provider. So a lot of the tools, or rather even just like the things that I think about or use as a doula, kind of transfer into that realm too. I see being a doula and an advocate as something that can't necessarily be separated. from each of those entities too. So something that I advocate for a lot when I'm working with clients, queer health advocacy, working with doula clients that I have, is changing the way that a procedure might typically be done to accommodate the patient's emotional needs. So maybe that might involve self-swabbing. Traditionally, we haven't seen self-swabbing used as much, especially like when somebody's having a sexual assault forensic kit collected, but it is something that can be done. And I have seen SANES here in Johnson County use that for when a person doesn't really want to be touched. I've also seen in Australia, there are self-administered pap smear programs that they have, and part of those programs were created to increase the number of people getting pap smears in the first place, but especially among the Aboriginal population, because they were least likely to seek out that form of healthcare, and the numbers of people deciding to go get a pap smear skyrocketed after they did a self-administered program, because oftentimes that creates more access for someone deciding to go through that regular cancer screening than, you know, having to face a lot of their sexual trauma and go in and get that exam done by another person. And they're also finding too that the samples that were collected from those self-administered pap smears are about the same quality too. Other things that I can think of might be using local anesthesia instead of general anesthesia. So sometimes, like especially with clients I've worked with that have a history of being assaulted while they were not conscious, maybe it was alcohol facilitated sexual assault, they have a fear of going under anesthesia because they know that whatever happens to their body after that point won't be in their control. And two, like I often advocate for going hand restraints, especially during C-sections. So you'll notice in the US, we strap people down to the table like they're on some sort of cross when they're going through a C-section. That's not medically necessary in most cases. They just do it out of an abundance of caution in case the person absolutely had a meltdown while it's happening. Never mind the fact that they can't physically move their legs because they have an epidural in place, and it's one of the few surgical procedures where a person is fully awake for it too. But sometimes, like even if anesthesiology is refusing to forego the hand restraints, then I might say, what if you just untied one of the person's hands and they could do whatever they wanted with the other hand? And sometimes they'll go for that. I also do a lot of advocacy for pain management. So people often see healthcare as something that's inherently painful. You just have to put up with it. There's no way around it. And that's not necessarily true. We have the technology, everyone, and we should be able to use it. So sometimes, especially for people with needle phobias that might need lidocaine patches before getting an injection or an IV placement. Also sometimes too, using anesthesia for certain painful procedures that you wouldn't normally see someone use anesthesia for. So I've worked with clients who said, I want to be anesthetized for my yearly pelvic exam that I get from my provider. And they would say, okay, like we have the ability to do that. Or other times too, giving them sedatives so that they feel like they can calm down for those procedures too. And I also like try to prompt providers to encourage full disclosure about all aspects of the procedure. So oftentimes I'll see providers talk about every last thing about the surgery, but they won't talk about tools or the fact that once that person is going to be put under anesthesia, the gown that they're wearing currently is going to be taken off of their body and they will wake up in an entirely different gown. And that can be really triggering to a person. So I think it's necessary to talk about that too, or other things, like I think with a lot of gynecologic surgical procedures, there's often a pelvic exam that's done as a part of that, and it has the ability to be done while the patient's awake. There's not really a lot of medical reasons for why, or sometimes even there's not really a medical reason for the exam in the first place. So then I ask questions like, are there going to be any sort of other examinations or internal examinations that you think that person may want to know about before they consent to this surgery? Also too, like, has the provider named all the medications that they're going to be using during a procedure? Sometimes I see providers will use drugs that have the effect of erasing somebody's memory. as a part of really invasive procedures, or sometimes just like outpatient surgeries in general. And that's something that the client's really not okay with. And they don't even know that that medication is going to be used on them. So it's necessary to ask questions that you wouldn't necessarily think of as being a problem before you're going into the surgery too. Another step that I take with clients is that I often accompany people to surgery up until the point where they're put under anesthesia. And the reason that they ask for that is because they're wanting to have advocacy services for the full extent of them being awake. And then I get to go into the post-op rooms afterwards when the person is recovering. But part of our local hospital's policy is that I can't be present when a person is being put under anesthesia. And sometimes like asking for these extra things is perceived by many other entities as like a pain in the butt. So I'll work with a lot of RNs who will really gatekeep that too, even though there's not a medical reason for why they don't want that person to have an advocate, don't want that person to have pain relief, don't want that person to be able to go under anesthesia. They'll sometimes tell somebody that's not possible. There's not a medication that can do that for you. And then we find out from the provider, actually, yes, there is. And so it takes a lot of persistence to do this advocacy in these spaces. But I think the persistence is really worth it, because when you're in the vulnerable position that the client's in, you can't always be persistent on behalf of yourself. Let's go to the last one that I've got, at least by myself. Okay. Something that I want to remind y'all of, this is something that I start out with when I'm talking to my clients for the first time and having an appointment where we sit down and we talk about what their healthcare goals are. The first thing that you need to know is that they're not allowed to not allow you. What that means is oftentimes healthcare providers will say you're not allowed to leave the hospital, you're not allowed to go out on a cigarette break, you're not allowed to eat something during labor, you're not allowed to refuse this exam. And none of that's true. They're not in charge of you. And I mean, there are, of course, like cases where minors are involved, and that can get really complicated because people believe that they own the bodies of minors and will make decisions on behalf of them. But what I'm working with adults, I especially say they're not allowed to not allow you, because you are hiring your healthcare provider to perform a service and you are paying them with the use of your insurance. In theory, you're kind of their boss, because you're also the boss of what gets to happen to you. So something I want you all to note too is that hospital and clinic policy are not law, and they never have been law. Some of them are influenced by laws, but you have the right to leave whenever you want to. And sometimes I'll see providers say, well, your insurance won't cover it if you check out against medical advice. And the research shows that's actually not necessarily true. In the majority of cases as well, you have the right to informed consent, you have the right to refuse treatment, and you also have the right to receive appropriate treatment for your condition. And that means evidence-based in some cases, and in some cases, it may not necessarily be evidence-based, but it's what that person emotionally needs. So there have been times where, like, I've worked with clients and they've said, I really wanted an episiotomy because I wanted to be able to control when I could tear. I knew I was going to tear. I just wanted to be able to control when. Whereas we know evidence-based care says that doing an episiotomy without a medical indication to do so is particularly a bad idea, and often increases the extent to which a person is going to tear if they tear in childbirth. But I still advocate for that person to get that episiotomy if that's what they want, because of that power and control over what happens to their body for them, not about what the so-called best treatment is for them, because they're the expert on themselves. Similarly, you have the right to switch providers. And I think people forget about this a lot too. So you can fire your provider at any point during your care, and that's 100% okay. And you should be allowed to do that. It gets a lot more complicated in rural areas where there are limited providers too, especially in Iowa, where we have a shortage of obstetricians and gynecologists as a whole generally, but you still have the right to switch providers or fire that person if they're not providing good care to you. And in most cases, you also have the right to access your medical records. So sometimes will see people be denied the right to access their medical records, or they'll be charged an outrageous fee if they try to get those mailed to them or released to them in some form. And if you look at the way that HIPAA is constructed, that's also against the law too, because they have to be charging you a reasonable fee, and you have to have the right to access your medical records and know what information's in there. And sometimes too, if you're looking at incidents of medical violence that have happened to you and you're trying to identify who did something to you, it may be in your medical record logged somewhere which providers that you interacted with. And so sometimes too, like when I have a client that suspects that they've been subjected to medical violence, we'll go and we'll take a look at that person's medical record to see if there's anything in the notes that seems out of order in some way. And there have been times where we did find something that was amiss, or otherwise evidence that medical violence happened while that person was under anesthesia. And that can be a really difficult situation. But having access to that medical record is one of your biggest tools in trying to look at what options may be after going through an act of violence. Let's go to our last activity.
All right, thank you, Storm. So now we're gonna do an activity where I'm gonna stop sharing for, actually I'm not gonna stop sharing. I'm just gonna switch. Storm, can you see the next screen now? Okay.
All right, so this will be a portion for which I'm gonna ask you to raise your hands or contribute into the chat for a lot of it. So we're going to kind of create some of these answers together, and then we have the ability to give this out to all the participants, don't we? Yeah. Okay, and so then we're going to give you all this list to take home. It's a little.
All right. So the first question are, what are ways you will incorporate content from today into your organization or your agency? You can raise your hand or you can type into the chat function.
Well, we got somebody raise their hand. How do I call on you? Okay. Hey there.
Hello. One of the things I think would probably be bringing the information on doulas, because I never really thought about that beforehand and how that can be helpful.
What was that again? Brain?
Sorry, my speaker is not that great. One of the things would be informing the rest of the people that I work with about the doulas. That was something that I never thought would be important. I just never considered it before.
Thank you.
Thank you.
What are some other ways you all will incorporate content from today into your organization or agency?
There we go. Provide a better understanding of patients' rights to the clients. Someone raised their hand. Hey.
Hi. Well, I don't really work a lot in the medical aspect, but I have learned a lot. I'm a mother myself. Granted, that was a long time ago that she was born, but I never thought of a lot of these things during birth that I had the right to consent to or not. Like, it was just kind of amazing how many different things that you had the right to say no to that I wouldn't have never have thought of while I was in labor or, you know, going through all that stuff. So I know I would definitely like to pass along that to other mothers or other people that don't realize that they don't have to have their arms strapped down. Like that just gives me anxiety thinking about it. So those little things were really, really important to me that I can pass on to other people.
What were the 2 things that were really important to you? I'm sorry.
Well, like the fact that like having the arms strapped down during a C-section. I always thought that you had to, that was a requirement. And like, as you were saying, that you can say no. And I didn't know that, or being able to eat or have water while you're in labor. Like you just assume that because they're medical professionals that you have to listen to them.
Something about power dynamics there.
Yeah.
Mm-hmm. Right.
Passing on the knowledge that you have the right to say no. Thank you. We have another person raise their hand. Hello.
Hello. So I think what I'll really would like to take away from this is I have a client who is expecting and she's a survivor. And I think that going through and creating not necessarily a norm, like a birth plan, but talking about things to expect and things that she does have control over would be really helpful. You know, so kind of like a birth plan, but in the way of what she would be comfortable with, what she wouldn't be comfortable with, and how to say no to that if that's what she chooses.
Yeah, that's like constructing a birth plan. Like,
yeah, not in the typical way, you know, you're thinking about it, but it really is just like creating a plan if, you know, if somebody's in a domestic violence situation, just kind of sometimes writing it out and thinking about it helps when you're in a heated moment with a lot of emotions and feelings. So
yeah, especially like considering the amount of physical pain that's often involved with birth too.
Yes,
like really
I was so blown away the first part 1 of this, like when I had one of my daughters, the doctor wasn't arriving yet, and so the nurse held my daughter's head inside my vagina until the doctor arrived and basically was pushing her in. So when she was born so fast that, I mean, her face was so swollen and puffy and had marks all the way down like her nose and her chin.
Yeah.
And we both ended up getting sick. Both had fever. She couldn't maintain her temperature. It was bad.
So it sounds like from your personal experience that like even if you would have had an advocate and or a doula, that would have like greatly impacted your situation also.
Absolutely. I had no idea.
For sure. Thanks for sharing, Mandy.
Yeah, thank you.
Storm, can you read some of the ones from the chat?
Let me see what we've got in here. I'm trying to think of where you left off at. Information how to, okay, so we got, oh yeah, y'all had lots of ideas. Better understanding of rights, looking with a much wider lens with individuals accessing services to provide support, information on how to advocate in non-emergency medical settings, letting others in my agency know that many of us are experiencing the same situations and continue to work on educating medical staff and others on what victim rights are. Good. Speaking with survivors and my agency more about how we can provide medical advocacy other than DVSA exam ER response. Yes, I'm really big into that one a lot. Non-emergency medical advocacy is really important. And then someone else wrote, I also think about mental health care choices postpartum often. This is how we address postpartum depression versus exploring what options might be available. Yeah.
Were you reading those for me or for you?
I think that, well, let me see where you left off at. Okay.
So now we'll just go into the second one. What are some ways you can help address and end obstetric violence? Okay.
Okay, we got someone who raised their hand. Yay. Hi.
I think just continuing to educate not only women, but also their significant others and
Birthing people?
that works. Of what their rights are.
Yeah.
Yeah, that's a good one. Others, what are some ways we can help address and end obstetric violence?
Can I add one?
Yeah, please.
Okay, I'm adding one in there. I think building relationships with, like, having your agency build relationships with your local birthing centers and hospitals, especially their obstetrics and gynecology departments, to help foster a more trauma-informed approach to birth care.
To adopt, say that again?
To adopt a trauma-informed approach to birth care. And then I saw somebody write into the chat, my OB-GYN is aware of my work as an advocate. She's very trauma-informed with myself and others. She's also open about not knowing how to do certain things like conducting sexual assault exams. I know she's open to having my agency speak with her practice about our services, and I'm sure providing education on obstetric violence. Good, yes, building that relationship. Another person wrote in speaking up and offering training on asking for consent. So yeah, like promoting that consent culture in the culture of medicine.
And maybe the individual who wrote about their OB-GYN being trauma informed, like recommending that same provider to other folks, right? As a way to get them to someone else who is like trauma informed. Even if it doesn't have to be your clients necessarily, but even like letting other folks know, like, hey, there is this trauma informed individual in our or a practitioner in our area.
Yeah, keeping a list of the people you know who know how to do this trauma-informed work is really beneficial. I actually have like a couple lists within our VAP of therapists and healthcare providers that I know work well with the populations we serve.
Thank you all. So the next one is how do these things, so how does any of what we've talked about today align with what you already do? And I know you all do great work because we're all part of Iowa CASA, and I know they're holding us accountable for being the best advocates that we can be, right? So what are some some things that you all do that like already align with this?
Ooh, we got stuff really flowing in right now. Okay. We've got one person said it's what we do. Another person said educating people on their rights. Oh, and the one person that wrote is what we do, also noted to follow up with that, or should do.
Yeah, so it's what we do, and it is what we should be doing. And if you're not, the good thing is that like once that means like you're at the bottom, and like there's only one way to go from there, right? And so that's up. So like you can start today. Educating people. Storm, what are some things that you already do that align with this?
Align with all of this. I think I actually focus a lot on working with providers too. So I train providers intermittently throughout the year to date. I know I've trained like anywhere between like, I want to say like 400 and 500 providers on especially like using a trauma-informed approach in healthcare and working with survivors of medical violence, especially. Also like doing these webinars, and recently I did a podcast that was on medical violence and directed mostly at providers who are listeners about how to improve their communication with clients too, because so much of medical violence happens through communication, or piss poor education rather.
Mm-hmm.
Ooh, I saw somebody wrote in there, making consent second nature. And another person wrote, empowering people to be able to speak up for themselves.
All right, and so we're gonna end this with talking about like, how do you all take care of yourselves, right? So thinking of like, yes, thinking of self-care, but actually one of the things I wanna mention is one of the things we talk about a lot at RVAP is community care, right? Like if I'm exhausted and I'm not taking care of myself, there's no way that I'm showing up being like the best that I can be, right? Which also means that I'm not giving those who I serve the best me, and then probably also not my colleagues. So I'm curious, how do you all take care of yourselves? And I really, even more than like thinking of like the things that like people like boast about, like what's your boring self-care? Like what do you do? You can raise your hand and or type in the chat. I think we can all agree that the work we do is hard and challenging. And so making sure that like we refill our cups, right? That we like are taking care of ourselves. Ooh, a nap, yes. Nap queen here. I like that example.
Disconnect when I feel things in my gut. Card games on my phone, just zone out. Oh yeah, like your phone is the best stim toy. It has everything you could ever want and more as far as a stim toy goes. Remember to eat and drink water. Oh yeah, water all day, every day. Go to the dentist, chiropractor, other physical appointments.
Whoever wrote the thing about going to the dentist, I'd love to talk to you about like making that part of myself, like more part of my self-care and less of like the torture.
Oh, they have many, many ideas. Okay. Okay.
Ooh, coffee. Okay. And Twitter together.
That's the way I do Twitter. Not forgetting to keep your personal interests and wine. And
Yes.
watching TikTok.
We're going to put that in capital letters, wine. We could be friends is what I'm learning.
Adult coloring books. Oh yeah, those are at every single training I've hosted with RVAP. We've got coloring books or coloring sheets.
One of my favorite gifts I ever got was when like adult coloring books were becoming a thing. And I got one with like swear words, and I felt like the naughtiest kid in class. Yeah, sobriety, that's huge. Yeah. I also like that, like sobriety that could be like multitude of things, right?
Yeah. Play with your dogs. Lighting candles and enjoying their scents.
Yeah, these are all amazing. The adult coloring books with swear words. Nice. TikTok. I'm still learning that. How's TikTok spelled like that?
I think it's that. Yeah. I miss Vine. Do it for the Vine. There's a lot of doulas on TikTok too. So like, if y'all want to like learn more about birth stuff, there's doula TikTok out there. Water the plant babies. Yes. Do we want to wrap up and give them some time for questions?
Yeah. 1 second.
Okay.
Okay. Well, thank you all. I will be sure to give this to Jocelyn to get this sent out to everyone. I do want to add the plant baby because that's very much a part of my life. So like nurturing something that's not myself or not yourself. I definitely thought that was someone else who had made that example, but welcome that from anyone. I thought it was Nadia from Iowa Casa who said the plant babies. All right, so I will stop sharing this.
That wraps it up, I suppose, y'all.
Thank you all for helping us make that list. And so now we'll open it up for any questions that folks have. Also, here's our contact information. So for the questions, you're welcome to either type them into the Q&A or into the chat or raise your hand and we can let you unmute you also.
Oh, RVAP, it stands for the Rape Victim Advocacy Program. We're located in Iowa City and also in many parts of southeastern Iowa. I think we've got an own office in Mount Pleasant, Keokuk, Burlington. If I'm missing one, somebody should tell me.
So we do 8 counties. Yeah. The counties are Johnson, Washington, Iowa, Van Buren, Keokuk. I know these. There are two more. Lee.
Lee,
Oh,
not
not Keokuk. Keokuk is the big city there. Gotcha. Thanks, Deanna. Des Moines.
Des Moines County.
I'm missing one more. Cedar. There we go.
Iowa. Thank you.
And I know that, well, I'm like, I always think like, oh, we have so many counties. And then I learn about, when you learn about like other regions that have like double this number, or almost double, I'm always like, oh, we have 8 counties. So.
Were there other questions?
There is one.
There's a Q&A.
Yep.
Oh, we have a Q&A. Thank you.
We're gonna answer this live.
We are, okay.
There's someone asks, is there part 3? And where folks can learn how to become as cool as Storm.
Or Shalisa.
Storm and I also provide workshops for doulas. And so if anyone does work with doulas or medical providers and you all would like Storm and I to show up, we do a workshop that is similar to this, but different. Of course, it's for providers. And we've gotten some pretty good feedback.
Yeah, we actually did a condensed version of both of these workshops together for, I think it was like the Central Iowa Doula Association recently. And I've also done some workshops for the Doulas of Iowa City. They're like kind of a business collective, and if you're a member of it, you can promote your doula business at these gatherings that they have 4 times a year, and you get shared continuing eds. And that's what a lot of these doula associations are about, is just like having that peer support.
Mm-hmm.
Ooh, yeah. Oh boy, buckle up.
It's Storm, I'll start and then you can.
Okay.
So the question was, how do you become a doula? There's a couple different ways. Storm and I became doulas through Advocacy. And well before either of us were doulas, we were providing support to folks who were pregnant, whether they were terminating pregnancies or actually going through with them. And so I know that we both came to doula work from just being an advocate, right? And so you can become a doula by going through, like, there's a training and there's some continuing ed around it. I would say I would start with DONA, D-O-N-A, and go through that program. I'm also biased. I went through DONA. There are lots of other organizations that also provide the training. If you are an individual who's a person of color, or you serve primarily people of color, specifically Black and or Latinx, you should, if you contact me, I can get you the name to some organizations that are not actually here in Iowa, but that are, one's not very far, just in St. Louis, and a couple other organizations that provide workshops and or training around providing support to folks of color as a doula.
Yeah, and I would say, like, something to note too about most mainstream organizations. I've taken training actually through 2 different organizations. I took birth training through CAPA, and then I took postpartum training through DONA. And I think it's important to, like, really examine the organizations that you're getting training from, because their philosophies will impact what the training is that you receive. So there have been, you know, some organizations are very, like, capitalist centered. So they have, like, their, I guess, like, their idea around it is that people should be paid for their labor. But also sometimes, like, certain organizations will then take a stance against nonprofit doulas who are providing services for free. Some also have stances against providing birth support to unassisted births too. And if you violate any of their codes of conduct, you can lose certification with them too. So, like, I personally had a preference for DONA out of the 2 that I took training with, and that was because part of CAPA's code of conduct was that you couldn't attend an unassisted birth. And when things are getting particularly dicey, especially with medical violence and obstetric violence, there are times where people feel the need to exit and exit promptly and check out against medical advice. And CAPA's direction was to stop advocating for the client immediately or being their doula, because that's just the way that they do things. And I didn't really agree with that, but there are also like a variety of reasons why they put that in their code of conduct too. So it really just depends on how the individual feels and what their values are as a doula. But I would say DONA is probably the one that's existed the longest in the United States. I think it's like, it's actually, no, it is. It's as old as me, because it was made in 1992 and I was born in 1992. Yeah. So it's been around for a while, and then some of the others followed suit. But also too, like, you can get practice being a doula just by doing the work and providing labor support and self-education. Some people have a preference for certification because it's thought that, like, in the future we will have the ability to get doula services covered by insurance, and that'll require certification. Others are like, it's a money-making scheme. Oh, we're over time. Sorry. Okay. Well, thank you for letting me know. I tend to go
Always. I got it.
Well, thank you for coming to our webinar. I enjoyed all of you being present.
Yes. Thank you, Shalisa and Storm, and to all of the participants. I do just have one announcement. If you checked the participants and you were not there, please let me know, email me. We're having some issues with people sharing their link to other co-workers or stuff that happens. And so email me if you do not receive your certificate from us. And with that, I think that is everything. Feel free to reach out to Shalisa and Storm. They are awesome. If you do have any follow-up questions. And this recording will be made available through our website. Yeah, that's everything. Thank you. Have a nice day.